Okay, let's unpack this. Imagine a patient walks into your clinic with knee pain after, say, an awkward twist. Or perhaps a footballer limps off the pitch after a tackle. Knee injuries are incredibly common, aren't they? And amongst them, well, meniscal tears stand out as one of the most prevalent challenges we face in orthopedics, often quite perplexing too. So today, we're embarking on a deep dive into the world of meniscal tears. We're going to peel back the layers right from their intricate anatomy to the subtle ways they present, how we diagnose them with precision, and then the full spectrum of treatment and rehabilitation strategies. Things that, truly enhance patient outcomes. By the end of this conversation, you should have a really systematic, nuanced approach to understanding these injuries, hopefully equipping you with the knowledge to navigate even the complex cases. Joining me today to unravel all of this is an absolute authority in orthopedic medicine. Welcome.
Thank you. It's a pleasure to be here. Yes, it's a fundamental, yet, as you say, undeniably challenging aspect of knee pathology. It's a topic that really constantly demands our attention and a refined understanding.
Absolutely. So, before we even consider what goes wrong, could you walk us through the basics? What exactly are these structures we call menisci, and what vital, almost underestimated roles do they play in the knee joint?
Well, at its core, the knee joint, which is a surprisingly complex hinge joint, really, it relies heavily on two crescent-shaped fibrocartilaginous structures. These are the medial and lateral menisci. You can think of them almost like, well, perfectly sculpted wedges. Or shock absorbers.
Okay.
They're not just passive pads, you see. They're incredibly dynamic components. And collectively, they cover a significant portion, roughly 70% of the tibial plateau's articular surface.
70%, wow.
Indeed. Their primary functions are quite profound. Firstly, they are critical load transmitters and shock absorbers within that tibiofemoral joint. Just imagine the tremendous forces going through your knee with every single step, every jump. The menisci ensure these forces are distributed effectively across the joint surfaces. They prevent that sort of bone-on-bone grinding and protect the delicate articular cartilage.
Right. Crucial protection.
Absolutely. Secondly, their wedge shape actually deepens the articular surface area. This significantly improves joint congruency, making the knee far more stable than it would be otherwise. They actually act as a secondary stabilizing mechanism within the joint. Okay, so stability as well as cushioning. Exactly. Now, what's really fascinating from a structural point of view is their composition. Around 70% of each meniscus is made of type I collagen, and this is arranged primarily in these incredibly strong circumferential fibers. That unique arrangement is what lends them their remarkable resilience, their ability to withstand significant compressive and shearing forces without simply collapsing. It's a masterpiece of biological engineering, really.
That structural design, the collagen arrangement, it sounds absolutely key to their function and their resilience, as you say. And I recall there's something quite distinct about their blood supply that really impacts how they heal, isn't there? It almost sounds like a tale of two zones within the meniscus.
You've hit on a critical point there. The vascularity is indeed paramount. It directly influences a tear's healing potential. We categorize the menisci into distinct zones based precisely on this blood supply.
Okay.
Think of the peripheral one-third, often referred to as the red zone. Think of it like a bustling city center with a fantastic road network for blood vessels.
Right.
This area is well vascularized, primarily supplied by branches of the medial and lateral genicular arteries. So tears within this zone, they have the highest potential for spontaneous healing or indeed successful surgical repair.
Because the blood's getting there.
Precisely because there's ample blood flow necessary for tissue regeneration, bringing all those healing factors to the site. It's like having a dedicated repair crew with all their tools readily available. Conversely, the inner two-thirds of the adult menisci is largely avascular. This is what we call the white zone. It receives nutrition predominantly through diffusion from the synovial fluid, which is far less efficient.
Right. Much slower.
Much slower, much less efficient. So healing in this area is consequently far more challenging. It's like a remote village where getting supplies is a real struggle. Then there's also the red-white zone, which lies in between, possessing a more limited blood supply, a sort of suburban area, if you like.
Okay.
This anatomical distinction is fundamental. It's truly the bedrock of our treatment decisions. A tear in the red zone might respond well to conservative management or repair, whereas a tear deep in the white zone often requires a different approach, usually excisional, removing the torn part.
That makes sense. It guides the whole strategy.
Absolutely. And beyond vascularity, something often overlooked, the menisci also play a proprioceptive role.
Ah, interesting. The sensory aspect.
Yes. The peripheral two-thirds contain nociceptive free nerve endings, pain receptors. Whilst mechanoreceptors are specifically located in the anterior and posterior horns, this sensory input contributes to our awareness of knee position and movement. It essentially tells our brain where our knee is in space.
Proprioception.
Exactly. So damage here can affect not just stability, but also balance and coordination.
It's remarkable how such a small structure can have such a profound impact. Mechanical cushioning, stability, sensory roles. Fascinating, particularly that proprioceptive aspect. Now, is there a difference in how the medial and lateral menisci are actually attached? Does that influence their susceptibility to injury? Because it seems one gets injured more often than the other.
Yes, absolutely.
Yeah.
There's a notable anatomical difference that directly impacts their vulnerability, and it's something we see reflected in the epidemiological data constantly.
Mm-hmm.
The medial meniscus has a much firmer attachment to the joint capsule and also to the deep fibers of the medial collateral ligament, the MCL.
Okay.
This makes it considerably less mobile. It's quite tethered down, you could say.
Right.
Compare that to the lateral meniscus. It has looser attachments with the joint capsule, and crucially, it does not connect with the lateral collateral ligament, the LCL.
Ah, okay. More freedom to move.
Precisely. It has far greater mobility. Now, this reduced mobility of the medial meniscus is a key factor in why medial meniscal tears are statistically more common than lateral tears in general clinical practice.
I see. It just can't get out of the way as easily.
That's a good way to put it. It's simply less able to move out of the way of potentially damaging rotational or shearing forces. This directly influences the epidemiological data we see, with medial meniscal tears being more prevalent, a point sometimes missed in a quick review of knee anatomy.
So if we connect this to the bigger picture, when you're assessing a patient with a suspected meniscal tear, your index of suspicion should generally be a bit higher for the medial side.
Generally speaking, yes, although, as we'll discuss, certain injury patterns might point more laterally, but overall, medial is more common.
Right. Good practical point. So understanding how they're meticulously built, let's now talk about how these amazing structures actually break. What are the common mechanisms and the key risk factors that lead to meniscal tears?
Well, meniscal tears broadly fall into two distinct categories, though sometimes they can overlap a bit. These are acute traumatic tears and degenerative tears, and their mechanisms are quite different.
Okay. Acute first.
Right. Acute tears typically occur due to sudden rotational or shearing forces placed across the tibiofemoral joint, especially when there's an increased axial load. Think about scenarios involving what we call increased degrees of closed kinetic chain flexion. That's essentially when your foot is fixed on the ground.
Like squatting or twisting.
Exactly. Kneeling, squatting, lifting heavy weights. These tears are also incredibly common in sports that demand rapid acceleration, deceleration, and quick changes of direction. Think football, rugby, skiing, activities with pivoting. A direct traumatic impact to the knee, like a fall or a collision, can also cause these tears. They often present as vertical longitudinal tears, and we typically see a peak incidence in individuals aged, say, 21 to 30 years, often athletes due to sports-related incidents.
Okay, the younger, more active group typically.
And degenerative. Degenerative tears, on the other hand, are more common in adults over the age of 40, and they can occur with relatively less force, often without a distinct inciting event at all.
So not necessarily a big injury.
Not at all. For instance, an awkward twist when simply getting up from a chair, or even just turning over in bed, might be enough to cause a tear in an aging, perhaps slightly worn meniscus. These are frequently associated with pre-existing osteoarthritis, where the tissue simply becomes worn over time due to age-related changes and cumulative stress.
Wear and tear.
Essentially, yes. They are more prevalent in older populations, making up about 30% of all meniscus tears. Peak incidence occurs in men aged 41 to 50 and women aged 61 to 70.
That distinction between acute, often high-energy trauma and the more insidious nature of degenerative tears is vital for our diagnostic approach, isn't it?
Absolutely. It shapes how you take the history and what you look for.
Given these mechanisms, who is most susceptible? Are there specific demographics, activities, or even pre-existing conditions that put individuals at higher risk?
Yes, definitely. Epidemiological studies, for example, from the U.S., indicate a general incidence rate of around 61 meniscal tears per 100,000 people. However, that figure jumps significantly, up to 8.7 per 1,000 in active-duty military populations.
Wow, quite a leap.
It is, and that immediate jump tells you there's a very strong link to demanding physical activities and repetitive stress.
Makes sense.
Occupations requiring frequent squatting or kneeling, Think plumbers, carpet fitters, construction workers, and sports with pivoting and cutting movements.
Mhm.
So soccer, rugby, football, basketball, skiing, wrestling. They all notably increase the risk.
Hmm.
We also see a higher incidence in males compared to females and in individuals over 40 years of age, largely due to those degenerative changes starting.
Right.
Interestingly, and as we touched upon earlier, medial meniscal tears are generally more common than lateral ones in the general population,
Hmm.
primarily due to that decreased mobility from its firm connection to the MCL. However, it's worth noting a key exception.
Oh.
In the setting of an acute ACL tear, lateral meniscal tears can actually be more common initially, right at the time of injury.
Ah, okay. So the pattern shifts with an ACL injury.
It can do. And this leads us to a really important clinical point. For those with anterior cruciate ligament, or ACL deficient knees. So an ACL tear that hasn't been reconstructed, there's a heightened risk of developing secondary medial meniscal tears over time.
Right. The chronic instability takes its toll.
Precisely. Particularly if that ACL reconstruction is delayed for over a year from the initial injury. It's almost as if the knee's instability puts extra stress on the medial meniscus.
That's a really key point for managing ACL injuries.
It is. Delay can have consequences beyond the ligament itself.
And what about younger patients? You mentioned tears are rare under 10.
Generally, yes, but there's an important exception. The presence of a discoid meniscus.
Ah, the anatomical variant.
Exactly. Most often occurring in the lateral meniscus, where it has an abnormal, usually more disc-like shape instead of the normal crescent. This can predispose younger individuals to tears at an earlier age because of its inherent instability and abnormal biomechanics. It doesn't function quite right.
So if you see a young child presenting with what looks like meniscal symptoms,
You absolutely have to consider the possibility of discoid meniscus. It needs specific management.
right. Okay, so once a tear occurs, and this is where it gets really interesting for diagnostics and treatment planning, how exactly do we classify them? I understand the morphology, the shape, and the location, especially relative to those vascular zones, are incredibly important. What's the key takeaway for us here?
Precisely. This is arguably the most critical piece of the puzzle for making treatment decisions. Meniscal tears are categorized by both their shape, their morphology, and their location. And we primarily visualize this on MRI scans. The key insight here for you in practice is that the vascular zone dictates destiny.
Right. That's the crucial link.
It is. A tear in the red zone is fundamentally a different beast than one in the white zone when it comes to healing potential and what you can realistically offer your patient. This isn't just academic, it's the bedrock of your treatment decision-making. On MRI, the presence of a high-intensity intrameniscal signal.
A bright line.
Essentially, yes.
Yeah.
A bright line on certain sequences, communicating with at least one articular surface on the otherwise black-appearing meniscal tissue that's usually indicative of a tear.
Okay, so what are the common patterns we see?
Right, let's briefly go through the common patterns. Each has distinct characteristics and, importantly, implications for treatment. First, we have horizontal or cleavage tears. These run parallel to the tibial plateau. They effectively split the meniscus into a superior and an inferior layer.
Okay, splitting it flat.
Exactly. They're more likely to occur in people over 40, often without a distinct traumatic event. They're often degenerative in nature. Healing potential for these is generally low because they commonly originate in that avascular inner zone and are exposed to constant shear stress during weight bearing.
Right. Bad location, bad forces.
Pretty much. Although, there's a fascinating nuance. Some central horizontal tears might experience better healing if they are subjected to more compressive rather than shear stress. Some studies report good healing with specific rehab protocols, but generally they're tough to heal.
Okay, what's next?
Next, longitudinal or vertical tears. These run perpendicular to the tibial plateau, but parallel to the meniscus's long axis. Think along the curve.
Mm-hmm.
These can occur in areas with better blood supply, often making them more amenable to repair, offering a greater potential for healing, especially if they're in that peripheral red zone.
So potentially repairable.
Potentially, yes.
Okay.
Then we have radial tears. These extend perpendicular to both the tibial plateau and the long axis of the meniscus. They typically start from the inner free edge and go outwards.
Like a slice through it.
Exactly. They are quite problematic biomechanically. A complete radial tear that extends all the way out to the meniscocapsular junction is, in functional terms, pretty much equivalent to a posterior root tear. It significantly disrupts the crucial hoop stress mechanism of the meniscus. It stops it working like a C-shaped ring.
Right, it compromises the whole structure.
It does. It effectively allows the meniscus to flop or extrude outwards, losing its shock absorption function. These often require surgical intervention to restore that hoop tension.
Okay. Very different implications.
Very different. Then we have complex tears. These just involve a combination of patterns, horizontal, longitudinal, radial elements, all mixed together.
Messy one.
You could say that. They are frequently seen with degenerative joint changes and typically not amenable to repair. They often lead to further joint degeneration and usually require a partial meniscectomy.
Right, just cleaning up the damaged bits.
Exactly. Then there are displaced tears. This involves either complete detachment or flipping of a piece of the meniscus into the joint. A specific and clinically very significant type is the bucket handle tear.
Ah, yes, the classic locking tear.
Precisely. It's a large fragment, usually from a complete longitudinal tear, that has actually migrated centrally, flipping over into the middle of the joint, over the remaining meniscus. These often cause severe mechanical locking symptoms, making it impossible for the patient to fully extend their knee. Interestingly, recent evidence suggests that for the newer generation all-inside repair devices, the reoperation rates and clinical outcomes are actually becoming comparable for radial tears and bucket handle tears, which is quite a promising development.
That is interesting. Better repair options.
Yes. We also classify flap tears, which are partially detached fragments, often from horizontal tears,
Right.
and ramp lesions.
Big lesions.
These are specific meniscocapsular separations found in the posterior inner part of the medial meniscus, usually, often in that well-vascularized red zone. They're frequently associated with ACL tears. Smaller ramp lesions may actually heal non-surgically, again underscoring that critical importance of tear location and blood supply.
Right. Location, location, location.
It really is key. Finally, root tears. These involve the detachment of the meniscus right at its posterior attachment, its root, onto the tibia, medial or lateral.
Okay. Where it anchors down.
Exactly. While less common, especially on the medial side, these can have incredibly significant implications for knee function. They often lead to rapid meniscal extrusion, where the meniscus squishes out from between the bones and very rapid joint degeneration. It essentially transforms a healthy knee into an arthritic one alarmingly quickly.
So quite catastrophic biomechanically.
They can be. Surgical repair is generally considered the most effective approach for these root tears, to try and restore proper knee biomechanics and prevent that almost inevitable cascade to arthritis.
Right. A lot to consider in the classification. So the specific pattern and, crucially, that vascular zone really dictate the likelihood of success for different treatments. That's a critical distinction for us to consider in clinical practice. Helps guide those patient conversations about prognosis and options. Now, let's turn to how these injuries typically present to us clinically. What are the hallmark symptoms a patient might describe? And what's the diagnostic pathway we should follow once they walk into our clinic?
Well, the clinical presentation is highly variable. It depends heavily on the injury mechanism, the type of tear, and any concomitant damage like an ACL tear. It's rarely a completely textbook case. Patients might report a distinct sensation of a pop with immediate knee effusion or swelling during a high-impact activity or acute trauma. This scenario is often associated with an ACL tear and a possible medial meniscal tear, as these injuries frequently occur together. The classic unhappy triad if the MCL is also involved.
Right, the combined injury pattern.
Exactly. In contrast, a fusion that develops more gradually, perhaps over 24 hours, is often more indicative of an isolated meniscal tear without significant ligamentous damage.
Okay, more subtle onset of swelling.
Yes, and symptoms can also be quite insidious, particularly with those degenerative tears. You might just see low-grade effusion and stiffness developing over several days or weeks without a distinct inciting event. Perhaps just after a prolonged period of activity, or even sometimes after rest. Pain is typically localized over the anteromedial or anterolateral joint line, although it can also be reported more medially, laterally, or even posteriorly, depending on the tear's exact location.
But the joint line is the key area.
It's a very common finding. But crucially, patients may also describe mechanical symptoms, and these are really our red flags for something catching or blocking.
Locking.
Exactly. Locking, where the knee gets truly stuck and can't be straightened. Clicking, which is often a reproducible sound or sensation. Or catching, where it feels like something is physically getting caught inside the joint. These all occur when torn pieces of the meniscus interfere with the smooth movement of the knee.
Mm-hmm.
They might also report an intermittent inability to fully extend the knee, what we call a fixed flexion deformity, or a feeling of the knee giving way, suggesting some instability. Sometimes, especially acutely, patients experience that popping sensation at the time of injury, followed perhaps by creaking sounds during movement. And in acute cases, the knee may feel warm to the touch due to the inflammation.
So a thorough history really eliciting those mechanical symptoms is absolutely paramount.
Paramount, yes. Distinguishing true locking from just stiffness is key.
And what about the physical examination? What objective signs are we looking for? And which special tests offer the most diagnostic value, especially thinking about sensitivity and specificity?
Right. A comprehensive physical examination should include careful inspection of the knee for any visible edema or swelling, any obvious deformity, then palpation, particularly of the joint line, assessment of standing and supine range of motion looking for any loss of extension or flexion, and muscle strength testing, though weakness is often secondary to pain. We also perform specific provocative tests.
Okay. Joint line tenderness first.
Yes. Anteromedial and anterolateral joint line tenderness performed with the patient's knee flexed to 90 degrees, perhaps dangling off the edge of the couch. This is a highly sensitive and specific finding. Reported accuracy is around 83% for both medial and lateral tears. If you can really pinpoint the pain exactly to that joint line, it's a strong indicator.
Right. Very useful clinically.
Very. Pain and deficits in either flexion or extension range of motion may also be present, depending on the tear type and the amount of effusion. A bucket handle tear, for instance, will classically severely limit extension. Whilst deficits in open kinetic chain knee strength testing are unlikely to be the primary finding, you might see an antalgic gait, a limp, to avoid pain or increased pain with single or double leg squatting due to those increased compressive forces over the menisci.
Okay. And the provocative tests, which ones are most reliable?
Well, the Thessaly test actually stands out with quite impressive metrics, around 75% sensitivity and 87% specificity in some studies.
How's that performed again?
The patient stands on one leg with the knee flexed slightly, say 20 degrees. They then internally and externally rotate their body on the fixed foot and knee, maybe performing a slight squat as well. If this twisting motion under load elicits discomfort, clicking, or a sense of instability or locking, it's considered a positive test. It's essentially trying to trap or pinch the torn meniscus between the femur and tibia.
Right. Simulates the injury mechanism.
To some extent, yes. The McMurray's test, though perhaps more widely known and commonly taught, actually has slightly lower metrics in some reviews, maybe around 61% sensitivity and 84% specificity.
Still useful, though.
Still part of the standard exam, yes. It involves passively extending the supine patient's knee from a fully flexed position up towards 90 degrees, whilst maintaining full external or internal rotation of the tibia. A palpable pop or click, combined with pain reproduction along the joint line, indicates a positive test. Traditionally, external rotation stresses the medial meniscus, and internal rotation stresses the lateral.
Okay.
Apley's compression test, where the prone patient's knee is passively flexed to 90 degrees and then rotated externally or internally with an axial compressive force down through the heel. This actually has quite low sensitivity, maybe less than 20%.
Oh, really?
Yes, but its specificity can be quite high, maybe up to 80–90%. So whilst it might miss a lot of tears, if it is positive, it's quite indicative of a meniscal problem rather than ligamentous.
Right. So useful like positive, but a negative doesn't rule much out.
Exactly. It's more about the combination of findings history, joint line tenderness, range of motion, and these tests that builds the clinical picture.
Given that variability in presentation and physical exam findings, which can sometimes be subtle, what imaging studies are absolutely essential to confirm the diagnosis and really characterize the tear, moving beyond just clinical suspicion?
Right. When a meniscal tear is suspected clinically, we always begin with standard radiographs, X-rays.
Standard views.
Yes, including AP, anteroposterior, lateral, oblique views, often a sunrise or skyline view for the patellofemoral joint, and crucially, weight-bearing views. These are vital not primarily for seeing the meniscus itself because it's soft tissue.
Right. X-rays show bone mainly.
Exactly.
Yeah.
But they're crucial to assess for any concomitant bony pathologies, like fractures, especially avulsion fractures near ligament attachments, to identify any loose bodies floating in the joint. And importantly, particularly in older patients with suspected degenerative tears, to assess for the presence and severity of pre-existing osteoarthritis. This significantly influences treatment options.
Okay. So rule out other things and check for arthritis.
Precisely. In young patients with an acute meniscal injury, these radiographs should typically appear normal, although occasionally you might see meniscal calcifications in cases of crystalline arthropathy, like CPPD, pseudogout, which can sometimes mimic meniscal tear symptoms.
Mm-hmm.
However, for actually diagnosing and characterizing the meniscal tear itself, magnetic resonance imaging, or MRI, is unequivocally the best modality.
The gold standard.
It's widely considered the gold standard for assessing soft tissues in the knee when compared to the ultimate standard of arthroscopy. It gives us incredible detail. MRI has demonstrated impressive accuracy, around 93% sensitivity and 88% specificity for medial meniscal tears, and maybe 79% sensitivity and 96% specificity for lateral meniscal tears. Pretty good numbers.
Very good.
MRI findings that strongly indicate a tear include that grade 3 signal we mentioned, the linear high signal, that bright line extending all the way to an articular surface,
Sure.
or the presence of a parameniscal cyst.
Yes. The cyst often points to an underlying tear.
It does. It's fluid leaking out through the tear. For specific tear patterns, particularly those causing mechanical symptoms like locking, MRI offers crucial insights. For bucket handle tears, for example, key MRI signs include the double PCL sign or the double anterior horn sign, where the displaced fragment appears next to these normal structures.
Clever signs to look for.
They are. Meniscal extrusion, where the meniscus is pushed out from its normal position between the femur and tibia, or a ghost sign indicating a loss of the normal meniscal signal where the root should be.
Yeah.
These might signal a root tear.
Which we know is serious.
Exactly. So MRI helps identify those high-risk tears too. If MRI isn't available or perhaps contraindicated, like with certain pacemakers, a CT arthrogram with dye injection or even ultrasound in experienced hands might be considered. But MRI remains the preferred and most comprehensive method. It allows us to truly see the tear in 3D, assess its type, its exact location, its size, and its relationship to the vascular zones. Invaluable information.
Absolutely invaluable for planning. Okay, so once diagnosed, often with that precision MRI offers, what's the typical treatment pathway? You've already hinted it's not one size fits all. It clearly depends on the tear, the patient.
That's absolutely right. Treatment is highly individualized. It depends on a number of crucial factors. The patient's age is important, their specific symptoms, especially those mechanical ones, their activity level and functional demands, and critically, the specific type, size, and location of the tear, particularly its vascularity. That decision matrix can be quite complex sometimes.
So what's the initial approach, usually?
Initial treatment for an acutely painful swollen knee where a meniscal tear is suspected often involves the classic Rice principles for acute soft tissue injury.
Rest, ice, compression, elevation.
Exactly. Rest from aggravating activities, regular ice application, compression with a bandage or sleeve, and keeping the leg elevated. Oral analgesics like paracetamol and non-steroidal anti-inflammatory drugs, NSAIDs such as ibuprofen or naproxen, are commonly prescribed to help manage pain and reduce swelling. Bracing or knee sleeves can offer some protection and compression. And early pain-free knee and ankle range of motion exercises are also encouraged, quite early on actually.
To prevent stiffness.
Precisely, to limit motion loss and also to help with edema control through muscle pumping action. Patients are typically advised to avoid exercises requiring maximal knee flexion, like deep squats, or using things like stair steppers or rowing machines, as these can exacerbate symptoms by compressing the posterior horns.
Okay, so initial calming down phase.
Yeah.
Then what? Conservative versus surgical?
Right. For simple tears, particularly those confined to that outer one-third, are well-vascularized red zone, and for many degenerative tears, especially in older patients, without significant mechanical symptoms. A conservative approach consisting of, say, 4-6 weeks of relative rest and structured physiotherapy is a very reasonable first line of management.
See how things settle.
Exactly. This allows us to determine if spontaneous healing might occur, or perhaps more commonly, if the patient can return to their desired level of function without needing surgery. Symptoms might just settle down even if the tear itself doesn't fully heal. In many cases, particularly for degenerative tears, non-surgical treatment has actually been shown in good quality trials to be non-inferior to arthroscopic partial meniscectomy in terms of long-term functional improvement.
That's a really significant finding, isn't it? Avoid surgery for many.
It is. It's a crucial consideration, especially in older patients without true locking or catching. It's a common misconception that all meniscal tears need an operation. Many don't.
That's a key message. So when do we shift gears and start thinking seriously about surgical intervention? And what are the primary surgical options available? Can you walk us through the nuances of choosing one over another?
Yes. Surgical intervention is typically considered when that conservative management fails to alleviate persistent symptoms after a reasonable trial, perhaps 6-12 weeks, or if the patient experiences significant, functionally limiting pain, persistent swelling, and particularly those debilitating mechanical symptoms, true locking or persistent catching, that significantly impair their function and quality of life.
Okay. So failure of non-op or significant mechanical issues.
Broadly, yes. The two main surgical approaches we then consider are meniscal repair and meniscectomy.
Repair versus removal.
Essentially, yes. Meniscal repair is generally the preferred option whenever it's anatomically and clinically feasible.
Why the preference for repair?
Because preserving meniscal tissue is absolutely crucial for the long-term health of the knee. Its removal significantly increases the long-term risk of accelerated osteoarthritis. This is due to decreased cushioning and increased force transmission across the articular cartilage surfaces. Think of it as sacrificing a vital shock absorber. You inevitably put more stress on the joint's delicate surfaces over time.
Right. Preserve the tissue if you can.
Exactly. The best candidates for repair are typically tears located in that vascular red zone, or perhaps the red-white zone. Tears shorter than about 2 centimeters. Vertical longitudinal tears are often good candidates. And acute tears, ideally those less than 6 weeks old, maybe up to 3 months. Acute tears repaired concurrently with an ACL reconstruction traditionally showed higher healing rates, likely due to the bleeding and growth factors released during the ACL surgery. Though, as I mentioned, current literature suggests maybe less difference now with modern all-inside repair techniques, whether done with an ACL or in isolation.
Okay. And success rates?
Overall, success rates for meniscal repair and appropriate candidates range quite widely, but are often reported between 70–95%, which is very encouraging when it works.
That's pretty good. What techniques are used?
Common repair techniques include the inside-out approach. This has often been considered the gold standard, especially for posterior horn tears. It involves passing sutures from inside the joint out through the capsule, requiring a small accessory incision medially or laterally to tie the sutures down securely.
Needs careful dissection outside.
Yes, you have to be very precise, carefully navigating neurovascular structures, like the saphenous nerve and vein medially, or the common peroneal nerve and popliteal vessels laterally. So it's technically demanding.
Right.
The all-inside technique is now probably the most common method used worldwide. It utilizes specialized suture devices with bioabsorbable anchors, allowing the repair to be done entirely arthroscopically without that outside incision.
Quicker, less invasive.
Potentially, yes. Though it comes with its own potential complications like device breakage, anchor pullout, or even iatrogenic chondral injury if the device isn't used carefully.
Trade-offs as always.
Always. There's also an outside-in technique, which is useful for more anterior horn tears. Generally, vertical mattress sutures are preferred biomechanically for their strength, as they capture those circumferential fibers effectively. And healing can sometimes be enhanced by rasping or needling the tear edges to try and stimulate a bleeding response from the synovium.
Trying to encourage biology.
Exactly. Post-operatively, after a repair, knee flexion beyond 90 degrees is typically restricted for about 6 weeks. And weight bearing is often limited too, to protect that delicate repair site while it heals.
Okay. So, quite a careful rehab after repair. What about the alternative meniscectomy?
Right, partial meniscectomy.
Oh.
This involves arthroscopically trimming away only the damaged, unstable meniscal tissue, aiming to preserve as much healthy, functional tissue as possible.
Just taking out the torn bits?
Essentially, yes.
Yeah.
Smoothing off the edges. This is currently the most frequent surgical treatment for torn menisci worldwide. It's particularly indicated for complex tears, degenerative tears with mechanical symptoms, or radial tears that aren't amenable to repair, or perhaps for cases where a previous repair has failed.
And recovery.
Patients often return to sports or full activities relatively quickly, perhaps within 6 to 8 weeks following this procedure. This makes it an attractive option for those needing a faster recovery.
But the downside, the arthritis risk.
That's the major concern. While it's highly effective for immediate symptom relief, getting rid of the catching and pain, about 50% of patients, perhaps more with larger resections, may develop radiographic changes consistent with osteoarthritis in the longer term. It highlights that trade-off between quick symptomatic relief and potential future joint health deterioration.
Right. A difficult balance sometimes.
It can be. Predictors of better outcomes after partial meniscectomy include being younger, perhaps under 40, having normal knee alignment, having minimal or no pre-existing arthritis visible on X-ray, and having a single, simple tear pattern rather than complex degeneration.
Okay. Are there any other surgical options? You mentioned transplantation.
Yes, for a very select group of patients, meniscal allograft transplantation is considered. This is really a salvage procedure.
Who's it for?
Typically for younger, active patients, usually under 50, who have had a previous near-total meniscectomy, especially of the lateral meniscus, which tolerates removal less well. And they must have persistent pain related to that meniscal deficiency, but crucially, have an otherwise stable knee without significant arthritis or malalignment.
So replacing the missing meniscus with donor tissue.
Exactly. It aims to restore some of the meniscus's function, reduce pain, improve function, and potentially prevent or delay the onset of osteoarthritis.
And recovery for that.
It's a much bigger undertaking. It requires a substantial recovery period, typically 8-12 months, for the graft to fully incorporate and heal biologically. Return to sports, if appropriate, generally occurs within 6-9 months, maybe longer.
Mm-hmm. And long-term results.
Long-term follow-up studies show generally persistent improvement in subjective pain and function scores compared to pre-op. However, radiographic progression of some degenerative changes is still common, unfortunately, and complications like re-tears or extrusion of the graft can occur.
So not a perfect solution, but an option for some.
An option in very specific circumstances. Contraindications would include things like inflammatory arthritis, significant instability, marked obesity, significant chondral damage already present, or unaddressed malalignment like being very bow-legged or knock-kneed.
Right. And you mentioned total meniscectomy is basically historical now.
Largely, yes. Its outcomes were consistently very poor in the long term. Studies showed pretty much 100% of patients developing significant arthrosis at 20 years post-total meniscectomy and 20% having major arthritic lesions even at 3 years. It just powerfully highlights the absolutely critical role of preserving as much meniscal tissue as possible whenever feasible.
A very stark warning from history. This really underscores the immense importance of choosing the right treatment for the right patient, that bespoke approach, as you say. And I imagine that getting the treatment right and getting it done in a timely manner makes a significant difference in preventing those longer-term, often irreversible issues like arthritis.
Absolutely. It is crucial wherever possible to seek appropriate treatment for symptomatic meniscal tears promptly. Untreated injuries, especially unstable ones, can progressively worsen. They can lead to further cartilage damage, significant joint issues, and ultimately accelerate the progression to degenerative arthritis. We know that the severity of degenerative changes is often directly proportional to the percentage of meniscus that was removed during previous surgery. That's a key clinical takeaway for us. More tissue removed equals higher future arthritis risk. Delaying necessary surgical intervention, especially for tears that are repairable, can exacerbate problems. The tear might become larger, more complex, or propagate into the avascular zone, making it unrepairable later. This can lead to greater instability and further joint deterioration over time.
So delay can turn a repairable tear into an unrepairable one.
It certainly can. And for younger patients in particular, this cascade can result in the need for partial or even total knee replacements much earlier in life than they otherwise would have needed them, maybe in their 40s or 50s. That significantly impacts their long-term quality of life and ability to remain active. It's a stark reminder that procrastination or perhaps inappropriate initial management can have severe consequences for a patient's future mobility.
A really crucial point about timely and appropriate intervention. Okay, so whether the path chosen is conservative or surgical, rehabilitation is unequivocally the critical next step for successful recovery. Could you outline the overarching principles and the typical phased approach to recovery, highlighting perhaps the distinctions between rehab after a repair versus after a meniscectomy?
Yes, rehabilitation is indeed the cornerstone of recovery. You can have the best surgery in the world, but without good rehab, the outcome won't be optimal. The aims are always to restore knee function, strength, and stability. Initially, for any symptomatic meniscal tear, whether managed conservatively or just after surgery, the management focuses on relative rest and avoiding activities that strain the knee.
Avoiding those aggravating movements.
Exactly.
Yeah.
Squatting, kneeling, twisting those closed kinetic chain movements we mentioned earlier. Ice therapy is recommended acutely to decrease swelling and pain, and the knee should be elevated when resting. Early isometric exercises for the quadriceps are introduced almost immediately.
Why so early?
to support the joint, minimize muscle inhibition, which happens very quickly with knee pain and swelling, and prevent muscle atrophy. Quads control the knee, so keeping them active is vital. These are done without excessive stress on the joint itself.
Yeah.
As mentioned, patients are typically advised to avoid exercises requiring maximal knee flexion, like deep lunges, stair steppers, or rowing machines, as these can put undue stress on the healing or irritated meniscus, particularly the posterior horns.
Okay. And the overall goals.
The overall goals are clear: reduce pain and swelling effectively, restore full pain-free range of motion, improve muscle strength and endurance, not just in the quads, but hamstrings, glutes, calves too, and importantly, optimize neuromuscular coordination and proprioception, getting that sense of joint position and control back.
Right. Retraining the whole system.
Exactly. For non-surgical treatment, success is often indicated by minimal swelling, the ability to bear weight comfortably without a limp, and achieving full range of motion with perhaps only mild discomfort at the very extremes of flexion, allowing them to return to their desired activities without significant limitation.
That makes perfect sense. So what does this phased rehabilitation approach typically look like in practice? Particularly thinking about the different considerations for a delicate meniscal repair versus a more straightforward partial meniscectomy.
Right. We typically follow a structured, criteria-based phased approach. It needs to adapt based on the patient's specific injury, the surgical procedure, if any, and their individual progress. It's not just about timeframes.
Okay. Phase 1.
The initial phase, generally the first couple of weeks, maybe up to week 4-6 post-op for a repair. This focuses predominantly on protecting the repair or letting inflammation settle, increasing passive and active assisted range of motion carefully, and managing acute pain and swelling. Exercises like gentle passive knee flexion, maybe wall slides where the good leg helps, can be used to facilitate flexion, often with specific limits after a repair, say 0-90 degrees initially. Once they achieve that comfortably, maybe heel slides can replace wall slides. Isometric quadriceps exercises, quad set straight leg raises, continue to be crucial for muscle activation and preventing that disuse atrophy. Electrical muscle stimulation might be employed if there's significant quad inhibition.
So controlled movement, minimal stress.
Exactly. And crucially, for repairs, there are often weight-bearing restrictions. Maybe non-weight bearing or touchdown weight bearing for several weeks, gradually progressing as healing allows.
Okay. Intermediate phase.
In the intermediate phase, spanning perhaps weeks 3 to 6 for a meniscectomy, maybe weeks 6-12 for a repair, strengthening exercises are cautiously introduced and progressed. This is where closed kinetic chain exercises like mini squats, leg presses, step-ups can begin, often once the patient can manage basic quad activation exercises without pain or compensation. We start light and build up. A running program might be initiated, often with a walk-jog progression on a treadmill, perhaps once quadriceps and hamstring strength reaches about 70–80% compared to the uninvolved leg, as assessed by functional tests or maybe isokinetic testing if available.
Right. Need that strength base first.
Absolutely. Need adequate muscular support for the impact of running to minimize re-injury risk. Range of motion should be nearing full by this stage, especially after meniscectomy.
And the advanced phase, getting back to sport.
Yes, the advanced phase, from weeks 6-12 onwards for meniscectomy, maybe month 3-6 plus for repair. This shifts focus to more dynamic, functional, and eventually sport-specific activities. Isotonic strengthening for hamstrings and hip muscles, glutes, abductors, becomes more intense. These are crucial for overall lower limb power, control, and stability during landing and cutting. Agility drills, cone drills, ladder drills, plyometric exercises, hopping, jumping, bounding are gradually introduced once sufficient strength, endurance, and control are demonstrated. Track running progresses. The progression here is highly tailored to the person's individual activity goals. Returning to recreational jogging is very different from returning to competitive rugby.
Absolutely. Needs careful guidance.
Very much so. Now, regarding those post-operative rehabilitation differences again, for meniscal repair, as we said, a more extended period of weight-bearing limitation is typical. Full weight-bearing generally postponed for 4-6 weeks, sometimes longer depending on tear type and surgeon preference, to protect that delicate repair site.
Right. Allowing biology to happen.
Exactly. Allowing the stitches and the biological healing to take hold without undue stress tearing it apart. The emphasis remains on managing pain and effusion while carefully progressing ROM and strengthening protocols, often with those strict limits on flexion initially, maybe avoiding deep flexion for 3 months or more.
So a much slower, more cautious progression.
Definitely. The full recovery timeline for a meniscal repair allowing return to high-impact sport can typically take 3 to 6 months, sometimes even 9 months or longer for complex repairs or revisions.
Okay. And meniscectomy rehab.
In stark contrast, partial meniscectomy rehab is usually much quicker. It often allows for immediate or early weight bearing as tolerated. Because no tissue healing is required, it's simply trimming away unstable fragments and letting the inflammation settle.
Mm.
Return to sports or full activities is typically much faster, often within 3 to 6 weeks for simple cases, maybe 6 to 8 weeks for more complex ones, assuming good progress with physiotherapy.
Big difference in timelines. Important to manage
Yeah.
expectations.
Critically important. A patient's overall health, their adherence to the physiotherapy plan, their motivation, and their pre-injury physical activity levels all significantly impact the speed and efficacy of recovery, whichever path they are on. Furthermore, factors like a balanced diet, adequate protein intake for tissue repair, and consistent engagement with the exercises also facilitate the process. It highlights the holistic nature of effective rehabilitation.
Absolutely. It's a partnership between the patient and the therapy team.
It really is.
Okay, we've covered a lot on diagnosis, treatment, and that crucial road to recovery. Now let's pivot briefly to the proactive side. What actionable steps can individuals, maybe particularly athletes or those in physically demanding jobs, take to try and prevent meniscal tears in the first place? And then what are the longer-term implications if these injuries are not appropriately managed?
Right. Prevention involves a multifaceted approach. It's centered on proper training, good conditioning, and developing better movement awareness, aiming to reduce undue stress on the knee joint. It's about building a robust, resilient foundation.
Okay, strength training is key.
Firstly, yes, strength training. Strengthening the muscles around the knee, particularly the quadriceps, hamstrings, gluteals, and calves, is absolutely crucial. Strong muscles provide better dynamic support and stability for the knee joint, helping to control movement and mitigate injury risk during physical activities, especially those involving sudden twists and pivots. Incorporating regular strength training enhances joint stability and shock absorption.
Makes sense. What else?
Secondly, flexibility and warm-up exercises. Dynamic stretches rather than static holds before activity and light aerobic exercises as part of a comprehensive warm-up routine are vital. These increase blood flow, improve muscle and tendon elasticity, effectively preparing the body for activity and potentially preventing injuries by allowing tissues to elongate more safely under load. Similarly, cooling down after workouts helps maintain muscle elasticity and aids recovery.
Good prep and recovery.
Yes. Thirdly, proper technique and movement awareness. Education on correct body mechanics in sports and daily activities is vital. For athletes, this means coaching and practicing appropriate cutting, landing, and pivoting patterns to minimize undue stress on the knee joint during play. Good neuromuscular control.
Landing softly, controlled turns.
Exactly. For anyone, it means being mindful of awkward twisting motions, especially when lifting heavy objects or squatting down. Using hips and legs, not just twisting the knee.
Okay. And returning after a break.
Fourthly, gradual return to activity. This is particularly important for our so-called weekend warriors, or anyone returning after an injury or a period of inactivity. Individuals should gradually reintroduce high-impact exercises in sports, ideally under guidance from a healthcare provider or coach. This ensures they avoid sudden, large increases in training intensity or duration that can overload tissues and predispose them to re-injury or a new tear. That too much, too soon is a common pitfall.
Very common.
Finally, lifestyle considerations. Monitoring activity levels is important, avoiding those sudden spikes in intensity. Regular lower-impact activities like cycling, swimming, or using an elliptical trainer can help maintain cardiovascular fitness and knee health, support joint stability, and promote cartilage health without excessive wear and tear. These can contribute to long-term knee resilience. And of course, maintaining a healthy body weight significantly reduces the chronic load going through the knee joint with every step.
Right. Less load, less stress. It truly sounds like a holistic approach to fitness, and mindful movement is absolutely key for prevention. Now, turning to the flip side, if these tears aren't managed properly, either conservatively or surgically when needed, what are the potential long-term complications patients might face? What are the really serious consequences we're trying to avoid?
That's a critical question, and it's the one we often have to counsel patients about most carefully when discussing treatment options and the importance of following through. The most significant long-term concern, and the one we consistently observe in clinical practice and long-term studies, is the almost inevitable progression to knee osteoarthritis.
The wear and tear arthritis.
Exactly. Studies consistently indicate that individuals with significant meniscal tears, particularly those where substantial meniscal tissue has been removed surgically, have a markedly increased likelihood of developing knee arthritis in the affected compartment in the future. This can lead to severe long-term disability, chronic pain, loss of function, and a significant reduction in quality of life. As we discussed, the severity of those degenerative changes is often directly proportional to the percentage of meniscus that was removed. Every gram of meniscus counts for long-term joint health.
That direct link is so important.
It is. And while surgery offers solutions, it also carries inherent, albeit generally rare, risks. We have to mention those. Things like postoperative blood clots, DVT or PE, infections, which can be devastating in a joint, or iatrogenic damage during the procedure to nerves, blood vessels, or even the articular cartilage itself. Patients may also experience complications related to anesthesia or issues arising from the surgical site itself, like persistent swelling, stiffness, or wound healing problems.
Risks with any intervention.
Always. And crucially, as we touched on, delayed intervention for tears that would clearly benefit from repair can exacerbate existing problems. The tear might become larger, more complex, displace, or heal in a bad position, leading to greater instability and further joint deterioration over time.
Right. Missing the window for repair.
Exactly. And for younger patients, in particular, this failure to intervene appropriately or in a timely manner can result in them needing partial or total knee replacements much earlier in life than they otherwise would have, potentially in their 40s or 50s. This significantly impacts their ability to stay active and their overall quality of life. This is why our initial decision-making repair versus removal versus non-op is so absolutely vital.
And functional consequences.
Functionally, untreated symptomatic tears often result in persistent pain, recurrent swelling, and those debilitating mechanical issues like locking or catching. These can significantly impair mobility and overall quality of life day to day. These functional limitations can then lead to compensatory movement patterns, limping, avoiding certain activities where the patient tries to offload the painful knee. This, in turn, increases the risk of further injury to other joints, like the hip or the other knee, or structures within the kinetic chain.
A knock-on effect.
Absolutely. It can create a vicious cycle of chronic pain, weakness, and functional decline, often accompanied by noticeable muscle atrophy, particularly in the quadriceps, around the affected joint. This is why a comprehensive rehabilitation approach, guided by physiotherapy, is essential not only for acute recovery after injury or surgery, but also to address these potential long-term functional implications. Restoring strength, range of motion, and neuromuscular control is key to breaking that cycle.
Really highlights the importance of that whole patient journey, not just the initial treatment.
Absolutely. Long-term view is critical.
This deep dive has really highlighted just how complex meniscal tears can be. From the initial diagnosis, understanding the tear pattern and location, through to the treatment decision-making, the surgery itself if needed, and that crucial long-term management, including rehabilitation and preventing future issues. It strikes me that achieving optimal patient outcomes truly depends on a highly collaborative, interprofessional approach. Could you elaborate on the importance of the entire healthcare team in managing these patients effectively?
Yes, you've hit upon a critical point there. For any patient with a significant meniscal tear, particularly perhaps those presenting acutely or needing surgery, effective management is inherently an interprofessional team effort. No single clinician can or should try to do it all in isolation. Seamless handovers and clear communication are paramount.
So who's typically involved?
Well, it often begins perhaps with the emergency department physician or a GP for the initial assessment and stabilization, maybe distinguishing it from other acute knee injuries like fractures or ligament ruptures. Then, nurse practitioners often play a vital role in the patient's journey and maybe an initial triage in some systems, providing patient education on initial management and home care, arranging investigations, and providing follow-up after their initial visit or post-operatively. The orthopedic surgeon is, of course, crucial for a definitive diagnosis, often interpreting the MRI in context, discussing treatment options with the patient, surgical planning, and then performing any necessary interventions, whether it's a repair or a meniscectomy. The radiologist is absolutely indispensable for that crucial imaging interpretation, providing the detailed insights from the MRI scans that really guide our diagnostic thoughts and treatment decisions. A good, detailed radiology report is worth its weight in gold.
Definitely.
And critically, the physiotherapist is fundamental, both for leading conservative management, guiding patients through non-surgical pathways with structured exercise programs, and also for providing that comprehensive preoperative preparation and, even more importantly, post-operative rehabilitation.
The cornerstone, as you called it.
It really is. The physio plays a vital role in following the prescribed plan, but also adapting exercises based on the patient's individual progress, identifying any issues early, and providing continuous feedback on that progress to the orthopedic team, often via the orthopedic nurse or directly to the surgeon.
That feedback loop sounds crucial.
It's invaluable. It tells us how the patient is actually responding to the plan in real time. Are they ahead of schedule? Are they struggling? Are they developing complications like stiffness or persistent swelling? The orthopedic nurse, in specialist settings, often acts as a key coordinator, ensuring seamless care transitions between hospital and community, answering patient questions, providing education on medication management or wound care, reinforcing rehab protocols, and keeping the treating clinician abreast of all developments. Monitoring for any complications or lack of progress between appointments
A linchpin often.
can be, yes. This coordinated communication and collaboration are absolutely essential because the recovery, especially after a repair, can often be prolonged. It requires consistent effort and adaptation from both the patient and the various healthcare providers involved. A unified approach where everyone, surgeon, physio, nurse, GP, and importantly, the patient is on the same page regarding the diagnosis, the specific treatment plan, the precautions, and the rehabilitation goals. This significantly enhances care coordination and ultimately the patient's long-term functional outcome.
Mm-hmm.
Whilst most patients, thankfully, do achieve a satisfactory outcome with good function returning to the knee, this is profoundly impacted by the team's ability to work together efficiently and effectively, putting the patient truly at the center of that care pathway.
A fantastic summary of the team approach. What an incredibly comprehensive deep dive into meniscal tears. From the intricate anatomy and that crucial insight that the vascular zone truly dictates the destiny of a tear, right through to the tailored treatment pathways and the absolutely vital role of rehabilitation. It's so clear that understanding these injuries requires a really nuanced and detailed approach for any medical professional dealing with knee pain. You've really demystified a complex area for us. Thank you so much for sharing your invaluable insights with us today. It's been incredibly enlightening.
It's been a real pleasure. The more we can foster this kind of shared understanding across the medical community regarding such prevalent conditions like meniscal tears, the better we can truly serve our patients and work together to improve their long-term outcomes.
Indeed. I couldn't agree more. And for you, our listener, we sincerely hope this deep dive has provided you with a clearer, more comprehensive understanding of meniscal tears, hopefully equipping you with the knowledge to approach these common cases with greater confidence and precision in your own practice. Perhaps it's prompted a deeper look into a particular classification of tear you encounter often, or maybe a specific rehabilitation phase that you'll explore further with your therapy colleagues. If you found this discussion valuable, please do consider rating and sharing this deep dive. It really helps more medical professionals benefit from these insights. Until next time, keep learning, keep questioning, and keep making those vital connections for better patient care.